and your colleagues and friends who are relating to Canada. First of all, let me express my sincere thanks to Dr. Calvin, and I also appreciate him for conducting this awesome academic excellence program over the last 3 or 4 years. After a lot of high-profile talks involving a lot of technical things in the afternoon by Dr. Savarani ma'am, Dr. Venkatesh, and Dr. Chan involving cardiac CT, we now go on to the very basic thing of blood pressure, which is a very simple thing, and this is something which spans all the boundaries and it cuts across all specialties. A patient with hypertension may be seen by a pediatrician, a physician, a surgeon, a physician, a cardiologist, or a nephrologist. Everybody sees a patient with hypertension. So we need to have a very good knowledge about this particular problem. That's what we are going to do the next 30 minutes or so. So why do we bother about hypertension? Because the cardiovascular mortality associated with high blood pressure increases with each 20 millimeters hike in the blood pressure, systolic blood pressure, as well as 10 millimeters diastolic blood pressure. It always doubles. Say when the blood pressure is in the normal range, when the blood pressure is in the normal range, the mortality is very less. But when the blood pressure goes up to the stage 1, the mortality almost doubles. When it goes to the stage 2, it is almost 4 times, and when the blood pressure goes up to stage 3, it is almost 8 times. Likewise, when you reduce the blood pressure, you get mortality benefit also. Say when you reduce the systolic blood pressure by about 10 millimeters of mercury, you get to reduce the risk of stroke by about 40%. And when you reduce the systolic blood pressure by about 10 millimeters of mercury, you get to reduce the risk of myocardial infarction and coronary disease by about 30%. The benefit of reduction of blood pressure is more with stroke rather than coronary disease. So we need to have a target-oriented reduction in the blood pressure in the management of these particular problems. The prevalence of hypertension is quite high in our population, but the awareness is very less, and the amount of people with controlled blood pressure is hardly 20%, and this is something we need to ponder as clinicians. So let me drive home some points regarding hypertension using a case scenario. So, 38-year-old male presents with vague symptoms like headache, neck pain, and dizziness for the last 15 days. He is also a smoker and a diabetic. His blood pressure is 130/85 on both arms with a pulse of 104 beats per minute. Such cases we keep seeing in our clinical practice day in or day out. Most of the times we are confused what to do with this particular patient, whether to start with antihypertensive drugs right away, or whether we need to follow these patients, or whether we need to inculcate on lifestyle modification, whether it is good enough to control the blood pressure. And if we decide to start these patients on antihypertensive drug, what drug to start? So these are all the points which should be running through our minds when we see such patients in our clinic. So there are some guidelines, and we need to know what to do when we encounter such patients. The European Society of Cardiology, the ESC 2024 guidelines, has simplified the classification of hypertension. Previously, we used to have high normal blood pressure, stage 1 hypertension, stage 2 hypertension, stage 3 hypertension. Everything was a little confusing. Because this has been totally removed, because there's not much of difference in choosing the drug in different stages of hypertension. So, all the stages has been removed. Now it is very simple. You have only 3 categories. Patients with non-elevated blood pressure, when you have the blood pressure of 120/70, the normal blood pressure is no more 120/80, it is 120/70. So when you have such a blood pressure, you call it as a non-elevated blood pressure, and you have a hypertensive level, when you have a systolic blood pressure of 140/90, you call it as hypertension. And in between values, that is elevated blood pressure, when you have a systolic blood pressure between 120 to 139 and a diastolic blood pressure between 70 to 89. This is called as non-elevated blood pressure. So when you encounter a patient with non-elevated blood pressure, there is a normal blood pressure, all that you need to do is to inculcate on values like lifestyle measures, and you have to have these patients on follow. That means any opportunistic screening is good enough to follow these patients. When you have a patient with elevated blood pressure, that is when the blood pressure is, the systolic blood pressure is between 120 to 129, which is quite common in our clinics, all that you need to do is to have a lifestyle measures and you have to follow these patients annually. That is very important. Every year you have to follow these patients. When you have a patient with elevated, just elevated systolic blood pressure between 130 to 139, and you don't have any high risk markers, we discuss what are the high risk conditions. When they don't have any risk modifiers in their clinical settings, or when the risk of developing cardiovascular disease is very less, these group of patients again can be followed up medically with lifestyle modification, and annual follow-up is all that needed. But when you have a patient with elevated blood pressure, the systolic blood pressure range of 130 to 139, but when they have a high risk conditions like diabetes, or when they have established cardiovascular disease, or when they have a family history of hypercholesterolemia or hypertension mediated organ damage, or when the risk of developing a future cardiovascular disease is quite high, when it is more than 10%, or when they have a risk modifier in their clinical profile, all these patients should be started on antihypertensive drug after a trial of lifestyle modification for about 3 months. So you start on lifestyle modification for 3 months. If the blood pressure is still high, then probably you have to start on antihypertensive drugs. Whereas the American guidelines is very strict. Even in this group of patients, they advocate starting off antihypertensive drug right away when the blood pressure range is between 130 to 139 of systolic blood pressure. When the blood pressure is high, that is hypertensive range, when it is more than 140 by 90 liters of mercury, that is an indication to start the antihypertensive drugs straight away along with the antihypertensive drugs. Coming to the patients which we saw, we had a patient who had a high blood pressure in the range of elevated blood pressure in the range of 130 by 85, which falls into the elevated blood pressure category, and he was a diabetic. So he should be started on a lifestyle modification initially, and after a trial of lifestyle modification, he should be put on antihypertensive drug. The blood pressure is not coming down. So we have certain guidelines to manage the patients appropriately. So we have to fit our patients in one of these categories and plan the management strategy appropriately. So these are all the high-risk cardiovascular conditions which might warrant the starting of blood pressure medication in patients with elevated blood pressure. You know what is called as elevated blood pressure? That is when the blood pressure, systolic blood pressure is between 120 to 139. That is called as elevated blood pressure. In such groups, when they have these conditions, probably you might have to consider starting on antihypertensive drug or a trial of lifestyle measure. So when the patient is having an established atherosclerotic cardiovascular disease like stroke or coronary disease, or when they have a established CKD in the form of a reduced eGFR, or when there is a albuminuria which is quite significant, or when they have a hypertension mediated organ damage in the form of LVH, or when they have a features of diabetic nephropathy or retinopathy, or when they have a diabetes, or when there is a history of familial hypercholesterolemia. These are the conditions when the patient is present with, and when they have an elevated blood pressure of 130 to 139, you might have to consider starting on antihypertensive along with the lifestyle measure. So there are certain risk modifiers which, when patients present with average risk, when they have these risk modifiers, again after a trial of lifestyle modification, you might have to consider starting them on antihypertensive drug, like high family history of coronary disease or atherosclerotic heart disease, or high risk ethnicity, or patients with high stress, or patients with autoimmune diseases or inflammatory diseases, patients with HIV. These are all the high risk modifiers. There are certain sex specific also, patients with pregnancy induced hypertension, patients with gestational diabetes, patients with recurrent miscarriages. These are all risk modifiers which pushes the patients with average risk to high risk, and you have to consider these patients to be put on antihypertensive drug after a trial of lifestyle modification. This is what the EC guideline says. And what are the drugs which are available? We're familiar with all the first line drugs, the ACE inhibitor, ARB, the calcium channel blocker, the main thing is the dihydropyridine calcium channel blocker, diuretics. These are all categorized as a first line management. In the previous guidelines, in the 2018 guidelines, they were considered basic drugs for hypertension. Whereas in the present guidelines, it has been prioritized as a first line management drugs. And how do you choose these drugs? Ideally, you have to choose the two drugs as a single pill. Dual combination of drug is the treatment which is needed in most of the patients. Either you can start with AC inhibitor along with the ARB and a calcium blocker, or AC inhibitor ARB along with the diuretics in the first step. In a dual combination in a single pill, if the blood pressure is not getting controlled, you can add the next drug. When you have started initially on a calcium channel blocker, you can add a diuretic. When you have started a diuretic, you can add a calcium channel blocker in the step 2. And if the blood pressure is still high, then probably you might have to consider adding a spironolactone. This is how the management of hypertension goes, and most of us, everybody is familiar with. And the NICE guidelines, which has been released in 2025, has given guidelines which tells what drug to prefer in which group of patients. Say when a patient with hypertension and you want to start these patients on drug, divide this patient whether it's a diabetic or a non-diabetic. The patient is a diabetic, then straight away go for the AC inhibitor or ARB as a first drug, and if the blood pressure is not getting controlled, go to the calcium channel blocker or a diuretic. When the patient is not a diabetic and you classify based on the age, if the patient is less than 55 years, then probably you have to start an AC inhibitor or an ARB, then go to calcium channel blocker or a diuretic. Whereas when the patient is more than 55 years, this is where the differentiation comes. It is not the AC inhibitor to be started, it is the calcium channel blocker which is to be started in patients more than 55 years, then go on to the ARB or AC inhibitor or a diuretic. This is what the NICE guidelines say. So we have some insights into the drug which has to be initiated in different groups of patients based on the clinical profile of the patients. So in the 2024 guidelines, we have the recommendation for other drugs like the patient is not tolerating the spironolactone, then probably we can supplement these drugs with epinephrine, and the patient is having a coronary disease, then probably you can consider using a drug called as beta blockers group of drugs, alpha blockers, hydrazine, potassium sparing diuretics. All these drugs has been included in the guidelines, and we have a big armamentarium of drugs in the management of hypertension these days, which has been recommended by the 2024 ESC guidelines as class 2A. Whereas the American guidelines, which has been released of late, is very strict in the numbers. You can see that the stage 1 hypertension values, the systolic blood pressure of 130 to 139 itself is classified as stage 1 hypertension, and straight away they ask these patients to put on antihypertensive drugs whenever they have a high risk conditions associated with it. And you can also see that the elevated blood pressure is between 130 to 129, whereas the ESC guidelines is a little broader in the scope. What does the Indian guidelines say? Indian Society of Hypertension guidelines are very vague. It almost follows the American College of Cardiology guidelines. Again, the stage 1 hypertension, again, it is very strict in the numbers. The systolic blood pressure values between 130 to 139 is considered as a stage 1 hypertension, and they have replaced the elevated blood pressure values as a raised blood pressure to reduce the patient anxiety with the terminology of elevated blood pressure. And managing the resistant hypertension is again a challenging problem. Let's see how to go about it. Initially, what is resistant hypertension? Say, for example, if the office blood pressure is 140 over 90 millimeters of mercury, despite using 3 or more antihypertensive drugs and at the maximum tolerated dose, including a diuretic, you call it as a resistant hypertension. In such cases, you have to ensure that the patient is taking drugs adequately. Drug compliance history is very important. You have to rule out pseudo resistance, and you have to rule out secondary hypertension also by your clinical examination. Once you have ruled out secondary hypertension and pseudo resistance, then probably you have to think of a true resistance, and you have to decrease the drugs. That is, you have to start adding the spironolactone, which is given a class 2A indication. If the blood pressure is still high, then probably you can add a beta blocker, if not added already. Then the blood pressure is still very high. You have other armamentarium of drugs like centrally acting drugs. We have the alpha blockers, we have the hydrazine, potassium sparing diuretics like amilorate. Can all be tried, but all these have a class 2A recommendation. That means it is a quite strong indication. The blood pressure is still very high. Then probably you can consider invasive therapy like renal denervation therapy, which is class 2B. So this is coming up in a big way of late. Let's see few slides on renal denervation therapy. So there is a renewal of interest in the renal denervation therapy, which is proposed as a management of hypertension. It is not a first line therapy for hypertension. So initially, the trial which showed a lot of benefit for renal denervation therapy was the simplicity hypertension 2 trial, which showed a reduction of blood pressure of 32 by 12 millimeters of mercury. But the initial enthusiasm was lost when the hypertension simplicity trial 2 3 was released, where there's not much of blood pressure reduction between the sham treatment group and the real patient group. Now the second generation catheters have been introduced, where they produce simultaneous and a helical lesion in the renal artery. A good knowledge about the renal nerves, where they have found that the renal nerves are concentrated more in the proximal as well as in the anterior part of the renal artery, so that they can produce a simultaneous renal innervation, producing a good result, has been studied with the recent trials, and it is coming up in a big way for resistant hypertension. So these are all some of the devices which are available for renal innervation therapy. You can use the radio frequency energy. There is also a device which instills the alcohol in the periadventitial tissue of the renal artery, the peritoneal tissue. There you can also use the ultrasound through a balloon catheter which is inflated in the renal artery to produce the renal innervation. Different methods of causing renal innervation therapy is available. And various trials like spiral hypertension on medicine trial, which has shown about 9 millimeters reduction in the systolic blood pressure and about 4 millimeters reduction in the diastolic blood pressure of medicines have been reported. And again, one important thing is all these trials have been followed up for long years, and even after 9 years follow-up, they have found that blood pressure reduction is sustainable even after 9 years. So we have a long-term follow-up of these drugs. A few words about the drugs, newer drugs like SGLT inhibitors. Dr. Venkatesh spoke about SGLT inhibitors in detail. Hypertension sometimes may be associated with the diseases like diabetes, CKD, and obesity. When you have such problems, SGLT inhibitor is an excellent adjuvant drug in the presence of diabetes and CKD and in patients with heart failure preserved ejection fraction. Hypertension is a condition which is commonly associated with the heart failure preserved ejection fraction. In clinic, sometimes you might see patients with hypertension coming with breathlessness. When you go and echo, you might see the blood left ventricular ejection fraction is quite normal, and you might be wondering what to do with these patients. You have to ask a cardiologist to evaluate for the diastolic dysfunction, and how to evaluate. Dr. Venkatesh spoke in detail. Cardiologist can really report whether the patient is having a diastolic heart failure, that is heart failure preserved ejection fraction. And when you find such a condition, the SGLT inhibitors are an excellent drug. That is the only drug which has got a proven track in the management of heart failure preserved ejection fraction, which is a common association with hypertension. It has got a class 1 indication, and everybody should take a note of it and keep using these drugs in patients with hypertension and shock. And this is another drug which is coming up in a big way. Of late, the GLP receptor 1 agonist, the liraglutide, the and the semaglutide, is an excellent adjuvant drug in the management of the comorbid problems like diabetes and morbid obesity. And when you have these problems, the semaglutide and the trizepatide has been shown that it's reducing the blood pressure to a bigger extent in all stages of hypertension. And the mechanism of reduction of the blood pressure in this group of patients through natriuresis, triglycerides, and weight reduction. And of course, it has got influence in the RAS inhibition also. This is a drug which Dr. Shokmar was alluding to in his talk on CKM, the pre-known drug which reduces the cardiovascular mortality and the CKD projection in patients with hypertension without the much incidence of hyperkalemia or gynecomastia. Newer drugs are on the pipeline. The hexacerone, which is a Japanese molecule, which is likely to be starting the Indian markets, is also coming up, and hopefully the cost also will be less when more drugs are available and the dependency is off, and everybody can use these drugs without the problem of hyperkalemia or gynecomastia. So this is evolving newer drugs. We know the established antihypertensive drugs acts on the angiotensin targets or the mineral receptor antagonist targets or the beta blocker, but there are other targets like angiotensinogen. There are other targets like aldosterone, where the drug can be used to inhibit the production of aldosterone. There are endothelin like targets. There are targets like angiotensin 3. Angiotensin 3 is something new terminology for so many of people. Let's run through quickly through some of these drugs. You might have heard the inclisiran, which is a drug which is used in the management of LDL. In one of the talks, somebody was alluding to that. And similar to that, we have the ziricesiran, which is a small interfering RNA, which reduces the angiotensin level by suppressing the production of the angiotensinogen. And this is given as a quarterly as well as biannual injection. But some of the problem with these group of drugs is this produces a permanent inhibition of the RAS system. So whenever the patient is having a hypertension or some form of shock, we never know how these patients are going to respond, because angiotensin and the sympathomimetic amines are the drugs which are really helpful in the management of the initial compensating mechanism of coping up with the shock. So that is a downside of this particular thing. We need to study all these things. The CRISPR technology is another promising tool, which is a gene editing technology whereby you target the angiotensin gene, and the certain genes, when it is targeted off, will help to reduce the production of the angiotensinogen. The problem is the off-target lesions, effects of these particular drugs, which is studied, the tumorigenesis and other things, and there are a lot of challenges in the delivery of this components to the target tissue. And there are other targets like aminopeptidase inhibitor, which inhibits the conversion of angiotensin 2 to angiotensin 3. Angiotensin 3 is a drug which is a molecule which is increasing the sympathetic tone and enhances the vasopressin release. So when you inhibit this particular conversion of angiotensin 2 to angiotensin 3 with this particular drug, there is a central RAS inhibition, and without the much influence on the renal parameters. Cubistat is a drug which is studied in the phase 2 trial, and it is awaiting approvals. And this is something which you need to keep into understanding and keep looking forward in the next 2 or 3 years, the aldosterone synthase inhibitors, because phase 3 trials have been presented in the recently concluded ESC and the ACC meeting. The lorundrostat, which is a 50 milligram dosage, which has got favorable effect in patients with obesity and hypertension. So the NOTCH trial is the one which was presented in the ESC, and endothelin A receptor antagonist, which is acting on the endothelin 1, which is a vasoconstrictor, and the zibosentan is the drug which is likely to antagonize the effect of endothelin 1, and this has got additional benefits like reduction of the HbA1c as well as the LDL. So these are all some of the drugs which we need to look for, and I'll rush through a couple of slides. The other newer drugs which are likely to be coming in the pipeline is the angiotensin 2 type 2 receptor agonist. Type 2 receptor is basically a favorable receptor which causes vasodilation and causes anti-inflammatory response, and when you stimulate these drugs, you have potential to reduce the hypertension mediated organ damage. This is in the phase 2 trial. The NPR receptor agonist, which is likely to act like a AMP or BNP, causing vasodilation, natriuresis, and this is going to offer a novel therapeutic target in resistant hypertension and in patients with heart with reduced ejection fraction. So we have to look out for all these drugs, and some of these drugs are available in an injectable form, which is going to be really handy for the patients because they don't have to take these drugs daily.